Hello everyone and welcome to today's webinar, Trauma Verification September Q&A Web Conference. I would now like to introduce Megan Hudgens, Trauma Verification Program Coordinator.
Hello everybody, this is Megan Hudgens, one of the Program Coordinators for the VRC, and thank you for tuning in for today's webinar. So I'd like to introduce some of our VRC staff. We don't have Tammy Morgan in the office with us today, but Molly Lozada is here, as well as Rachel Tanchez. Bumi Parikh will be coming in with the general questions, and we will also have a special guest, Amy Sveska, in a few minutes for a special segment regarding the National Trauma Data Standard. But first, we do have a disclaimer regarding CE. So to qualify for CE, you must attend at least 50 minutes of educational content. An email will be sent to all attendees who qualify for CE with instructions on how to claim CE. If you have any questions, of course, please feel free to email us at cotvrc@facs.org. You must watch this webinar prior to October 15th in order to claim your CE. So what's the goal for this webinar? Firstly, to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient Manual, to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patient. And secondly, to understand the processes and standards involved in an ACS Trauma Verification site visit, and how following these will positively impact the quality of care of the injured patient at your trauma center. Now let's get started. So as always, we do ask that you have a copy of the Orange Resources book on hand, either a physical copy, or of course you can always download a PDF at the link at the bottom of the slide. In addition, we will be referencing the resources manual often in the presentation, of course, but then also we will be referencing the clarification document, the most current edition, and the verification changelog, again, most current edition, in conjunction with the manual. These are also accessible on the website that is linked at the bottom of the slide. And the clarification document and changelog are excerpted here for reference. So these are released monthly. The changelog, as you would assume, notes criteria changes, updates, and so on. And the clarification document is just additional elaborations and clarifications on the criteria. So these are both available for download on the resources repository linked on the slide. So we do have all of our past webinar recordings all the way back through 2016 for your listening pleasure, to a count of, at present, 50 Q&A webinars, not including this one. These archives include both the video recording and a copy of the slides for your perusal. We do understand that this is an awful lot of content, but we do recommend that you at least take a moment prior to submitting your questions to at least look through the last few batches of slides. There are definitely hot button topics that come up a lot, and your question may well have been answered during a previous webinar. So just check back through the past 3-4 months or so and just see if we've already covered that topic. We do, of course, have the stakeholder public comment website, as well as a few tutorials, firstly, becoming a verified trauma center first steps, and becoming a verified trauma center site visit. So the Participant Hub, as always, we ask you to please keep your contacts in the Participant Hub up to date. When we send you your final site visit report, we will be checking the hub for whoever you have listed as your current TPM, TMD, and either your CEO, your president, or other administrative contact. If you haven't logged into the site in a minute, maybe just take a second after you view this webinar to just go double check that all of your contacts currently in the system are still the people that you want us sending things to. And lastly, we have our expanded FAQ, which covers some additional hot button questions. This page is broken down by chapter, so it's an excellent place to check for any specific queries and inquiries you might have about verification. So quick disclaimer, all questions are pulled directly from the question submissions. There have been no edits made to the contents. If your question is not answered today, the question may require more information and will receive a response from ACS staff within 1 week after the webinar. So now I'm actually going to turn it over to Rachel Tanchez with some scheduling reminders.
Good afternoon, everyone. The site visit application can be found online only and can be accessed on the following ACS Trauma website pages. As you'll see below, the VRC site visit application link right there, or on the Trauma Quality Program Participant Hub Account Center link. The ACS Trauma website pages will link to the Account Center page, and when you go into it, you'll see the Log On button there. And just as a reminder that this log on is not the same as the PR key login. In order to log on, you'll use your username and password that were emailed to you when you started the process of joining a trauma quality program. For example, those who participate in TQIP, this is the same password you would use to access the TQIP education portal. Once you log in, you'll see the first page, and you'll see this is the page where you can actually update your contacts or facility information, and you'll see there that you can request a site visit. You'll want to click on that. You'll see the application drops down, and the online application, we ask that you submit it at least 13 to 14 months in advance of the requested site visit date and must be before expiration date. You'll see that you can request an alternate pathway. This is for surgeons or physicians who trained overseas and want to participate in the trauma call schedule. Their CVs must be submitted to the COT VRC email, as they will be vetted by a subcommittee for eligibility to go through the alternate pathway. You'll also see on there that all Level 1 trauma centers must complete the Orthopedic Trauma Liaison OTL form, which can be downloaded on the site visit application. And you could also submit that form to the COT VRC email with a copy of the OTL's curriculum vitae. At this time, we are accepting applications for 2020 site visits. 2019 is closed. So once the application has been submitted, the VRC office will provide you with an email receipt of the confirmation. And then in about 5 to 7 days afterwards, you'll receive the logins to the online PRQ. The online PRQ can also be accessed at the following website, and a copy of the PRQ in Word can also be downloaded from the following link. We ask that you do not submit payment until you receive an invoice. You should receive this approximately 60 days before your site visit. And your center will be billed annually for the trauma quality program fee. This fee will not include any additional visit related fees such as additional reviewers. And then you can find the fee structure which is located at the following website address. And new participation fee schedule. So speaking of the fee, effective July 1st, 2020, the participation fee will increase. For a listing of the new fee structure, please go to the following link. The Trauma Quality Program includes participation in both TQIP and VRC. If you have specific questions about the Trauma Center's next invoice, please feel free to contact us at traumaquality@facs.org. Site visits are being scheduled quarterly. So at this time, the first quarter of 2020 is being scheduled. We ask that you provide exact dates that you would like to have your site visit on. The site visit will occur on those chosen dates, but may be asked for different dates should the review team be unavailable on the requested dates. So once the review team has been secured, you will receive a confirmation email approximately 120 days, give or take, prior to the scheduled visit. This will include your reviewers and their contact information. The ACS travel agent will arrange site reviewers' flights. Reviewers will make travel plans approximately 20 to 30 days prior to the site visit. We ask that the hospital will arrange and pay for the site reviewers' hotel accommodations as well as their ground transportation. Please contact the reviewers directly within 30 days of the site visit for their flight itinerary and any logistical information. We want to make sure that you are set up for a successful site visit.
Okay, thanks, Rachel. So we do have a few quick announcements. So this is the time of year where we talk to you a lot about the TQIP annual meeting. So an important reminder here regarding the TQIP meeting. Please book your hotel room by Sunday, October 13th. Reservations that are received after that cutoff date or after the room block fills will be subject to rate and space availability. So by all means, get in on that room block while you still have the option to do so. And for more information, of course, you can view the TQIP annual meeting website at the link below. So here's a list of all the pre-conference workshops we have. I've laid them out in more depth during the last couple of webinars, so I won't bog us down with the details here. But just as a reminder, we will have 2 optimal and topic courses this year spread out over 2 days, November 14th and 15th. These courses are really intended to coincide with each other. So we do recommend, if you're able, scheduling one for the first day and the other for the second day. We also, of course, are offering Stop the Bleed basic and instructor courses, and a bit of exciting news that is not included on the slide, but as of this month, over 1 million people across the world have now been trained in Stop the Bleed. So if you are not yet one of those 1 million, by all means, this is a great time for you to get in on that. And of course, all information about registering for these workshops can be found at the link at the bottom of the slide. So you may remember we had a note during last month's webinar regarding this question. This was in the PRQ Chapter 9, Question 18C, how many of these patients had neurological deficits? So last month we told you not to bother answering that question, and good news, now it's just not in the PRQ. So you can go ahead with 18A and 18B that are pictured below for pelvic ring injuries and all acetabular fracture patterns, and that will be it for that chain of questions. So a bit of information about the next verification Q&A webinar. The next webinar after this one will be released Wednesday, October 30th. The time it will drop will be 12 p.m. Central Time, and your deadline to submit questions will be Wednesday, October 9th. And so we do have an announcement regarding the future of the Q&A webinars to go over really quickly, and this is a pretty significant change, and as we move to the next slide, you can see we're actually transitioning to a quarterly Q&A web conference. So the last monthly Q&A webinar is going to be next month, October 2019. And after that, we're going to be going on a short hiatus through November and December. And then we will be returning for our Q&A webinar for the first quarter in January. So more information about specific dates will be presented as we get closer. And before you start getting worried, I will add this change is a temporary measure. We will be going back to a monthly drop schedule upon the release of the new resources manual, as we do naturally anticipate an uptick in your questions around that time. And with that noted, this is probably a good time to let us know if there's any additional discussion topics you would like us to cover in the next webinar. So October, as I said, is going to be our very last monthly Q&A. So if there's a specific topic that maybe you don't just have one question about, but would really like us to dive into in detail, please ask. In the past, we've done discussions on our PRQ validation process and a deep dive into Chapter 10 of the PRQ that we did last month. But if there's anything you'd like us to talk about, now's a great chance to have us do that. And now I'm going to turn it over to Amy Sveska, our Senior Program Manager in Data Quality, for a segment on the National Trauma Data Standard.
Hello, everyone. First of all, I would like to thank the verifications team for inviting me to come present today. And for those of you who don't know me, I am the Program Manager of Data Quality for TQIP. We do participate and provide webinars for the registry staff. And today, they have invited me to talk to you about the National Trauma Data Standard. Here it is. This is the data dictionary. And for the 2020 data dictionary, it covers patients who are admitted on January 1st through December 31st of 2020. And there is a kind of a distinction I want to talk to you about up front. And the National Trauma Data Standard, which is also known as the NTDS, defines the data elements. And then we have an NTDS work group, and they determine which elements are reported or included in the dictionary. And the cover of the dictionary hasn't changed in the past few years other than the data up front. And you can see here that where you can determine that this is for the 2020 admissions. Also, in the lower right-hand corner of the cover, we give a release date, and we do our book a little bit different than the Orange book because ours is updated annually. But if we do a revision, you will see that noted in the lower right-hand corner. If you haven't already done so, you can download the 2020 Data Dictionary at this link here provided at the bottom of the page. So a little history about the NTDS. Trauma centers have been collecting trauma data for a long time, but it wasn't until 2007 until this dictionary was published. And the purpose of the dictionary was to standardize or give a national standard for all of the data elements and determine which data elements are going to be reported to the NTDB. When it was originally developed, to describe the mechanism of injuries and severities in trauma centers. It was not developed for risk-adjusted benchmarking, which is why there's been a lot of changes over the past few years. If you think about it, healthcare prior to 2007 or even in 2007 was a fee-for-service type of business. Well, it is not that way anymore. What you're looking at here is a copy of the NTDS development cycle. And I'm not going to go over everything, but there's a few things I would like to point out. Anytime a data field or a data element definition is changed, or we introduce a new data element, it has to go through a pilot process. That pilot process typically is March through May every year. Then in January, we have to give our technical vendor, IQVIA, and all the software vendors the changes for the upcoming year. That gives them the opportunity to update their softwares, so come January 1, you all can abstract this data into your registry. So basically it takes 2 years, as you can see on this process, to make a change or add a new data element or even retire data elements into the dictionary. So I get asked a lot of times why we pilot these data elements and why it takes two years to get anything changed. Well, the one thing is we've noticed through history that when we do pilot these data elements, the first year that we receive the data or even the first quarter is much more reliable than if we don't, because the definitions are a lot more clear and they are more consistent. One thing that has not changed since the implementation of the NTDS Data Dictionary is the NTDS Patient Inclusion Criterion. So what we're going to talk about next is the 2020 NTDS Patient Inclusion Criterion. And as I mentioned earlier, anytime there's a change to the dictionary, we have to send it through a pilot process. And back in 2016, what we did was pilot a new NTDS Patient Inclusion Criterion. And that did not go as well as we planned. But what we did do is learn from the comments that centers gave us during that pilot. We sat back at the table, and the NTDS work group came up with another patient inclusion criterion that we piloted back in 2018. Well, that pilot went a lot better based on the feedback that we got in 2016, but for the third time, we went back to the people who participated in the pilot and asked them a few more questions before we decided to implement the new patient inclusion criterion. And I mention this because I want you to know that we didn't make this change lightly. There was a lot of thought and consideration into this change. Well, if you open up the dictionary, here's where you'll find the NTDS patient inclusion criterion. On the left-hand side, it's more of a list form, and on the right-hand side is an algorithm. You can see on the algorithm there's 2 steps. Here's step 1, and then we have step 2. So for the sake of today's presentation, we're going to go over the algorithm. And probably the best way to tackle this is you have to ask a lot of questions when you look at each patient. And the first question that you need to ask is, did the patient sustain 1 or more traumatic injuries within 14 days of initial hospital encounter? Now that's a big change, because in the past we never had any kind of time frame that we held centers accountable to. So for the injury date. So now we're saying only injuries within 14 days. If the injury was not within 14 days, then the patient is not included. If the injury is within 14 days, you want to go down to the next question. Is the diagnosis code for any injury included in the following ICD-10 CM range? Well, I'm going to tell you up front, I am not an ICD-10 coding expert, but what I do know is that these codes all fall within the traumatic injury range for ICD-10. So if they don't have any of those codes, then they're not included. If they do, the next question you ask is, did the patient sustain at least one injury within a diagnosis code range outside the ranges of the ICD-10 codes below? So these S codes that you're seeing here, what they are superficial injuries. So if the patient had a traumatic event within 14 days of initial hospital encounter, and the only injuries that they have are these S code injuries, which are external, then they would not meet the NTDS patient inclusion criterion. Now, if they had external abrasions and contusions or injuries along with other injury codes, then they would. And so you would move on now to step 2. So just keep in mind as step 1, they had to have sustained a traumatic injury within 14 days. That meets the acceptable ICD-10 code range. If they didn't, you don't even need to go any further. They don't meet the national standard patient inclusion criterion. If they do, you need to go on to step 2. So step 2, then, did the patient's injury result in death? If they did die of their traumatic injuries, then they are included and should be reported. If they did not, then the next question you ask, was the patient transferred from one acute care hospital to another acute care hospital? And before we go any further, because we will get questions about this, how do we define acute care hospital? Well, the CMS defines that for us, so we're asking you to follow the CMS definition of acute care hospital. A hospital that provides inpatient medical care and other related services for surgery, acute medical conditions or injuries, and it's usually for a short-term illness or condition. So, if they were a transfer from one acute care hospital, they had a traumatic injury that fell within the ICD code range, and their initial encounter was within 14 days, then they are included in the NTDS patient inclusion criterion. If not, you would move on to the next question, which is, was the patient directly admitted to your hospital? And then we have this, exclude patients with isolated injuries admitted for elective and/or planned surgical intervention. Now, I'm going to go on or talk more about that in a minute, but let's just talk about, was the patient directly admitted to your hospital? If they were, then they are included and they meet the NTDS patient inclusion criterion. If not, then you need to move on to the next question. Was the patient an inpatient admission and/or observed? If they were, then the patient is included and should be reported. If they were not, then the next question is, was the patient a trauma consult or any level of trauma activation? I'm going to stop here for a minute and just remind you that the patient had to have sustained traumatic injuries that meet that ICD-10 coding requirement within 14 days of arrival. If they did, and they were a trauma consult or any level of trauma activation, then they meet the NTDS patient inclusion criterion. If not, then the patient is not included. So I'm sure you have a lot of questions going on in your head, and that's okay because this is change and it's new. So what we're going to do is go over some scenarios and talk about what would or wouldn't meet the NTDS patient inclusion criterion. So you can see the first scenario here on your screen. We have a 16-year-old female who is playing fast-pitch softball and slides into third base and collided with another player. After the game, her parents drove her to the ER where she was diagnosed with a distal humerus fracture. The orthopedic surgeon applied a splint and discharged the patient home with instructions to follow up in his clinic. So, based on this scenario, let's see if this patient meets the 2020 NTDS patient inclusion criterion. And the answer is no. So, although the patient sustained a traumatic injury within the 14-day time frame, she was not transferred from another acute care hospital, there was no trauma activation or consult, nor was she admitted or observed, so she would not meet the NTDS patient inclusion criteria. All right, our next scenario is an 88-year-old female who tripped and fell. That same day, she was brought to your ER by EMS complaining of hip pain. X-rays revealed an intertrochanteric fracture. She was seen by orthopedics and admitted for surgical repair of her fracture. So, I wonder if this patient meets the NTDS patient inclusion criteria. And the answer is yes. So the reason is because the patient sustained a traumatic injury that met that ICD-10 coding requirement within 14 days, and she was admitted for surgical repair of her injury. Now we have a 31-year-old female who presents to the ED after an altercation with her boyfriend. The trauma surgeon was consulted and evaluated the patient in the ED that same day. She was diagnosed with contusions and abrasions without fracture of her right eye. So let's see if this patient meets the NTDS patient inclusion criterion. Well, she does not. And the reason is because she did not sustain a traumatic injury that met the ICD-10 coding requirement. So remember step 1, they have to have met an injury within that ICD-10 code range within 14 days of their initial encounter, and she did not. Okay, now we have a 50-year-old male who was the unrestrained driver involved in an MVC. He was transported to your hospital by EMS from a critical access hospital. His injuries were contusions and abrasions without fracture of his right eye, and after being evaluated by the ER physician, the patient was discharged home. So let's see if this patient meets the 2020 NTDS patient inclusion criterion. And the answer is no. Although the patient was transferred from that critical access hospital, which for the sake of this scenario we're going to consider an acute care hospital, the patient did not sustain a traumatic injury that met the ICD-10 coding requirement. All right, our last scenario is a 34-year-old male who was shooting hoops with his son when he fell and injured his forearm. That day he went to an orthopedic clinic and was seen by an orthopedic surgeon who diagnosed him with a radius ulna fracture, and they planned for operative repair the next week. So on February 8th, he was directly admitted to your hospital by the orthopedic surgeon for operative repair of his fracture. So, does this patient meet the 2020 NTDS patient inclusion criterion? And the answer is no. Although the patient sustained a traumatic injury that met the ICD-10 coding requirement, and it was within 14 days of his initial encounter to the hospital, he was admitted to your hospital for a planned surgical intervention of an isolated injury, which is excluded. So remember when we talked about in step 2, those patients that are excluded, this is an example of that. All right, I want to talk about an important email address and a website address. The first one is if you have any questions about the 2020 patient inclusion criterion for the National Trauma Data Standard or any data element definition that's in the National Trauma Data Standard, please send that to traumaquality@facs.org. This is the email address that we use, and these types of questions will be sent over to the data quality team, and we will answer your question within a few days. The next is a website for the NTDS Data Dictionary Revision site. And I told you earlier that we have an NTDS work group that determines which data fields are going to be in the dictionary. And this is a formal platform for you all to submit any suggestions on how we can improve the clarification of a definition, or maybe a suggestion to add a new data element, or maybe a suggestion to retire a data element. Whatever your suggestion or clarification is, this is the official platform, and the work group reviews those 2 times a year. So we're getting ready to meet during Clinical Congress, so if you have any suggestions or clarifications that you would like them to consider, you might want to do that within the next few weeks. All right, very similar to VRC's FAQ, the NTDS has an FAQ, and I wanted to provide that to you. Here is a website address that you can get to it, and you'll see right now we just have the 2019 NTDS Data Dictionary, but we will be adding the 2020 soon. As Megan mentioned earlier, much like the TQIP Registry Staff webinars who transitioned to going quarterly a few months ago, they're going to transition to go quarterly. And I can tell you from my experience with the registry webinar, people were concerned about not being able to get the CEs, and I get that. So I just wanted to show you, for you TQIP centers, the free education that is provided and that you get CEs for. And last year, for the 2018 TQIP conference, 17 CEs were offered. And I understand that not everybody can go to the TQIP conference. It's, time away, and it costs money and everything. I get it. But we do offer 2 online courses, which are dependent upon the level of trauma center or enrollment you are with TQIP. So there's a level 1 and 2 full online course. If you have never taken the online course before, you will have to take the full online course, and it offers 7 CEs. And as trauma program managers and medical directors, there is lots of information about the benchmark report, how to read the benchmark report, ideas where to start after you get your benchmark report on this online course, so I highly suggest that you take it. If you have already taken the online course before, we offered an abbreviated online course, and for level 1 and 2s you would get 4 CEs, and that's all the new things and changes from the previous course. And level 3s is the same. Their CEs aren't as many because level 3 courses don't report the TQIP process measure data elements. So that section of the course is not included for level 3s. And for our CE provider, every 50, as in 50 minutes of content equals 1 CE. Thank you very much for your time.
Well, thanks, Amy, for that wonderful presentation. Lots of good insights on that. So this is Boomy, and I'm going to be going ahead and presenting on the general questions for this month's webinar. So the first question is on trauma service admissions. So the question is, near drowning, admitted for near drowning pulmonary edema, should this be admitted to a trauma service, or is IM appropriate with trauma consult? So yes, it is acceptable to admit this patient to the internal medicine service with the trauma consult. However, the trauma surgeon should be involved to evaluate whether there are any traumatic injuries, whether that be strangulation, neck vessel injury, or cervical spine fractures, and also for the added benefit for rapid resuscitation if needed. So the next question is on verification site visit charts. Will we always need to print off charts, or when will the ACS go paperless, or at least somewhat paperless? So we understand that the preparation for the charts can be cumbersome, but currently the trauma centers have the option of using the EMR or printing the charts for an upcoming site visit. As a courtesy, we ask that you contact the lead reviewer to check to see if they would like something specific printed for the visit. It is also important to note that at some point, all hospitals will be shifting from paper to EMR. In the current review agenda, centers that will be utilizing the EMR are asked to have available specific documents printed on-site or tabulated. This will be presented on the next slide. So the EMR software must be easily tabulated to display the contents listed below. Some registry softwares can be programmed to be tabulated based on the requirements of the review agenda. If the EMR is not able to be tabulated, then the following contents must be printed for each trauma case. This includes the pre-hospital section, which is the EMS run sheet and transferring facility ED information, the trauma flow sheet, the H&P, the consult notes, the operative report and notes, discharge summary, autopsy report if available, and copies of the PIPS documentation and other related information if applicable. So the next question is, will the PRQ ever go away and the information just be pulled directly from the registry? We understand and appreciate everyone's patience with the PRQ. However, the PRQ will not be going away anytime soon. We are working on developing a more streamlined PRQ that will hopefully be launched in conjunction with the release of the new resources manual.
Hi everyone, this is Molly. I know there have been questions about our PRQ, and I'm pretty sure that people have heard over time about importing data that is submitted to the NTDB and TQIP that will pre-populate the PRQ. I just want everyone to know that that is part of our larger developing process for the PRQ. So I will talk a little bit more about that at the end of this webinar.
Thanks, Molly. So the next question is on the PRQ in the ICU section. So under PRQ section E, number 12, which is in chapter 11, does the trauma surgeon retain responsibility for the patient and coordinate all therapeutic decisions in the ICU? Would this be answered as yes if the trauma APP is coordinating care in collaboration with the intensivist, or would the trauma surgeon themselves need to be involved in all therapeutic decisions? So for this, the expectation is that the trauma surgeon is involved with all therapeutic decisions while the trauma patient is in the ICU under their care. If the trauma surgeon, trauma APP, and the intensivist are all involved in the care of the trauma patient, the PRQ would be answered as yes in this case. On the PRQ, we're asked for briefly list any weaknesses and how they were addressed. Do weaknesses equal opportunities for improvement from the executive summary from my previous visit? So yes, the terms weaknesses and opportunities for improvement are interchangeable. We are transitioning from the term weaknesses to OF5s. We understand that some trauma centers may have multiple deficiencies and or opportunities for improvement from the previous visit to report on the PRQ. Please note that the text boxes in the PRQ have character limits. Therefore, it is important to be concise in your responses. Another option is to list a few on the online PRQ and list the rest in a Word document. This document may be forwarded to the VRC office at the same time the PRQ is marked complete. We will then forward the copy of the document to the review team in their review packet. So the next question is completing data tables for pediatric programs. So we are an adult level 1 and pediatric level 2 facility that considers the pediatric population to be all patients under 18 years of age. The ACS considers pediatrics to be patients under 15 years old. Which age cutoff should I use to answer adult and pediatric questions on the PRQ to complete the pediatric data tables and pediatric adult hospital bed table? So great question. When the PRQ is asking about pediatric specific data, the expectation is that the data provided in the admit line should account for the ACS definition of pediatric patient, which is under 15 years of age, to meet the volume requirement. However, for purposes of completing the data tables in this instance, use your center's pediatric age. If we have an ACS adult and pediatric re-verification in June 2020, when would we expect to get the updated PRQ to fill out? So access to the PRQ will be provided shortly after the center has submitted an online site visit application request. This will be coming from Anita Johnson. Please note, changes to the PRQ are ongoing. Revisions are announced during the monthly VRC web conferences and by email to the TPMs that have an upcoming visit. As mentioned earlier, a new PRQ format that is more streamlined will be released in conjunction with the release of the new resources manual. So the next question is on non-surgical admissions. If our NSA percentage is over the 10% threshold, what is our requirement for ACS re-verification? So for centers that admit more than 10% of patients to a non-surgical admission, for centers that admit more than 10% of patients to a non-surgical service, the expectation is that a review is being conducted to ensure patients who may have benefited from a surgical consult receive one and that care was appropriate if they did not receive a surgical consult. For best practices, the PIPS process should review all non-surgical admissions. The next question is on board certification documentation. Do we need to show proof of surgeons' board certification in their specialty? So yes, please provide documentation on site that indicates the surgeon is board eligible for certification or current in their board certification, also known as continuous certification or maintenance of certification for their specific specialty. So the next question is on call schedules documentation. How far back do you want copies of the call schedules? So please have available on-site copies of the primary call and or backup call schedules for the last 3 months during the reporting year. Trauma record retention. For primary survey and trauma records for a level 3 trauma center, how far back do we keep our records for trauma patients from the last site visit verification, which was in March 2017? When do we need to follow our hospital's retention policy since they don't have a specific one for trauma records, but do have a 5-year retention on ED records? So the VRC does not have any requirements related to documentation and record retention policy. It would be advisable to follow your hospital's retention policy. Pediatric TPM. For a PEDS Level 2 facility, does the PEDS Trauma Program Manager have to also be over the Injury Prevention Department or just have active involvement with it? So the TPM for an adult or pediatric program is not required to also be the Injury Prevention Coordinator or in this case, over the Injury Prevention Department. In a Level 2 trauma center, the adult or pediatric TPM may also serve as the Injury Prevention Coordinator as long as it does not encumber their day-to-day duties as the TPM. Can a general surgeon not part of the regular trauma panel take backup trauma call, second call, without having to meet all of the requirements, such as the 50% PIPS meeting attendance requirement? Yes, the general surgeon may serve as a backup for primary call. They are required to be current in their board certification, but are not required to attend the peer review meetings. They must be able to receive information resulting from the peer review meetings. If at any time the backup surgeon serves on the primary call schedule, they will be required to meet the same requirements as the other panel members. Performance improvement. I have the clarification document from May 2019 as the latest document. I note admits, transfers, activation, and response times, non-surgical admits, changes in X-ray interpretations, mortality review, universal screening for alcohol on admitted patients with a stay of greater than 24 hours, attendance at trauma services meetings should all be monitored by the PIPS program. I was questioning whether there was an official number of PIPS items that ACS expects trauma centers to be collecting, analyzing, reporting out with the follow-up through the PIPS program. Another similar question that we got was, is there a list of all expected PI to be monitored per ACS guidelines? Is it the above and whatever else the trauma center sees as necessary to monitor? So in this case, all the standards are what the center has to monitor. For example, tracking ortho and neuro response times and any outliers are what will have to be reviewed through the PIPS process. I'm going to turn it over to Megan for the CD-related questions for this month's webinar.
All right, thank you so much, Bhumi. And let's get started with the CD-related questions. So, first question for the CD section is on limited activations, CD 2.8. As a Level 2 verified trauma center, we have 2 trauma activation levels at our facility, full and partial activations. Our trauma surgeons respond to all full activations. Emergency physicians with ATLS certification respond to partial activations. Is this practice of allowing emergency physicians instead of trauma surgeons to respond to partial activations, does it fall outside of the ACS Orange Book guidelines? will this policy receive a deficiency in an ACS re-verification? And this is from a level 2. Now, regarding what you may call partial, limited, level 2 activations, it's definitely an admissible practice to have the EM physician be the primary responder. What's really important here is that there are guidelines in place for when the trauma surgeon would be expected to respond and what types of injuries they should respond to. And to clarify, EM physicians who are boarded in emergency medicine and have taken ATLS at least once are an acceptable option for the primary responder, not in lieu of the trauma surgeon. They do still need to respond based on your criteria, but they may function as the primary responder. So here's a question on social work. For level 1 pediatric trauma centers, is it required that there be a designated trauma social worker, or is the requirement just to have social work consultation performed on each patient? Now, we always say that you should have a medical social worker available 24 hours a day, 7 days a week for level 1 or 2 trauma center. That said, this isn't a criterion point. The VRC doesn't require them to be dedicated to the trauma program. This requirement we're talking about here, 10.7, calls for a pediatric social work program that is available to provide evaluations and counseling for pediatric patients. Now, to hopefully head off a few follow-up questions that we may get for this one, in Chapter 10, Pediatric Trauma Care, page 67, Table 1 of the book, one potential point of confusion where pediatric social work CPS is defined as E and E for essential, please disregard this statement. So here's one for pediatric surgical critical care, CD 1017. If you have peds critical care medicine, do you need a pediatric surgeon with SCC? So we did break this one up a little bit as it was a multi-part question actually. But first thing to note, for L1 and L2 pediatric trauma centers, we don't actually require you to have a pediatric surgeon with SCC boards. We'll get into this more in detail on the next slide. Now, with regard to 1017, if we're talking about a level 1 pediatric trauma center, you must have 2 physicians that are boarded in pediatric critical care medicine, or as an alternative option, you could have 2 physicians who are boarded in pediatric surgery and SCC by the ABS. So either of those options would be sufficient to meet the criteria. And the second part of that question, also in 1033, there must be a surgical director of the PICU boarded in SCCC. Does that person have to be a pediatric surgeon, or can it be an all-ages surgeon with interest in pediatrics? So there was actually a change to CD 1033, and that change was that in level 1 and 2 pediatric trauma centers, they're no longer required to have a board-certified pediatric surgical critical care surgeon. And if you will note in your current edition of the verification change log, this is indicated as follows. The surgical director of the pediatric intensive care unit should be board certified in surgical critical care. So this is desirable, but it is not a must. So we have another multi-part question here. Is oral maxillofacial surgery coverage a required surgical specialty for level 2 trauma centers? If there are several specialties that have coverage sporadically, would that mean a deficiency could be cited? So to get into the first part, I can just note that oral maxillofacial surgery is not actually a required service at level 1 or 2 trauma centers, and we're going to get more into what surgical specialties you do need to have on the next slide. And the requirement for 1171 indicates that L1 and 2 centers must have a full spectrum of surgical specialists available, and we always stress that this is available at bedside when a consult is requested by the trauma attending. And this doesn't have to be an immediate response. We don't have a time guideline like we do with other CDAs, like 15 minutes, 30 minutes, etc. The time response is going to be determined by your guidelines, and we want to make sure that you are following your own criteria. So where you would run into trouble and where a deficiency would be cited is if the surgical specialists aren't available when a consult is requested by the attending based on the guidelines that you have already put in place. And as I referenced before, these are the surgical specialties that you would need to have for each level. So for L1, that would be, of course, orthopedic and neurosurgery, cardiac, thoracic, vascular, hand, microvascular, plastic, OBGYN, ophthalmology, otolaryngology, and urology. I won't read the whole list again, of course, for level 2, but it's basically all of those with the exception of cardiac. Cardiac is not required for a level 2. Now, for level 3, I know we've been talking mostly about L1 and L2 because that's where the CD applies, but to focus on L3s for a moment, the only subspecialty in this list that they are required to have is orthopedics. For the rest, it's certainly desirable. It's great if you have them, but it's not actually required for verification purposes. So here's one for registry concurrence. Please help define registry concurrence. Does this mean that in addition to all data fields and scoring, that all complications must be entered within 60 days? So concurrent, as we use the term in our official verification documentation, we define that as 80% of your charts are closed within 60 days of a patient being discharged. So when you see concurrent referenced in the Orange Book, clarification document, anything to do with verification, that is what we mean. So 80% of your charts are closed within 60 days of discharge. Here's one on injury prevention. Many TPMs have injury preventionist included in the job description. For a level 1 center, I see the ACS has identified specific criteria for that role. What is the injury prevention role for a level 2 center? Is there a volume requirement for a dedicated injury preventionist not included in the TPM role for level 2 centers? And so there's actually no volume requirement that's related to an injury preventionist for any trauma centers. The requirement that we have is that there is someone with a leadership position that has injury prevention listed in their job description. And at a level 2 center specifically, these duties may be part of the TPM's job description, just so long as they do not encumber their duties as TPM. So here's one on SBIRT for children. SBIRT adult level 2 center that also admits children but is not seeking combined pediatric level 2 verification. Does the SBIRT process need to be completed on the PEDS registry patients as well, using CRAFT on ages 12 years old to 17 years old, or just the adult registry patients using audit CAGE on ages 18 years and older? So all trauma centers, regardless of their separate or combined pediatric verification that admit children with a traumatic injury, are required to perform an alcohol screening, and the trauma program will determine what age that screening will begin. Some centers do use the age of 12, but again, this is going to be determined by your trauma program. And another one on alcohol intervention. Patients seen and discharged on Saturday and Sunday with positive alcohol level, we mailed the Rethinking Drinking booklet to their address in the system. Is that acceptable? So to clarify, our criteria indicates that 80% of admitted trauma patients with a stay greater than 23 hours are required to be screened. Those who screen positive must receive an intervention. So that's 100% of the 80% who screen positive. The type of intervention is going to be based on your institution's policy. So therefore, if you're providing a brochure or pamphlet, even if it's through the mail, that's a completely acceptable form of intervention. So that would be in compliance with the criteria. And we have a few questions, as always, on CME. First, for continuing education, what is the view of the ACS for continuing education for the trauma service staff? So if trauma service staff implies the trauma medical director, trauma program manager, and your trauma surgeon panel members, the requirement is as follows. So the TMD, of course, must maintain an average of 12 hours of CME per year. That adds up to a total of 36 hours over 3 years. Same for the TPM, 12 hours per year, 36 over 3, except, of course, it's CE instead of CME. And then trauma surgeons presently will maintain their CME through board certification. And another question on CME. Clarification for the new CME requirement says participating on the trauma call panel, staying current with their board certification satisfies the CME requirement. Do we have to demonstrate that they are staying current with their board requirements, i.e. if they are halfway through their board certification, show that they have half of their required CME hours? So yes, this may be demonstrated by having a copy of the provider's board certification, continuous certification, or maintenance of certification document available on site for the reviewers. And now I'm going to turn it over to Molly Lozada with an update on the resource manual chapter revisions.
Hi everyone, thank you for joining our webinar today. I gave a brief update last month about the chapter revision process, and I just want to reiterate that we are still working on the revision process and want to cover just a couple of things based on Amy's presentation on the NTDS patient inclusion criteria changes and how that would impact trauma centers. As you can see in this month's webinar, we got several questions about how that new NTDS is going to impact staffing, and if there's going to be any changes to the 500, 750 records that we ask in the criteria. And I just want to say, to put everyone at ease, there is going to be a change. Hopefully it's for the better. Unfortunately, because that chapter literally is going to be reviewed in the next couple of weeks, I cannot disclose what that number is going to be, but it is going to be there is going to be a change. So I didn't want to answer these questions specifically. What I may do is, or what I will do is, I will reach out to the folks that submitted these questions directly and respond to those. Basically what I've said here, that there's a change that's going to be coming. There is going to be a change to the number, but I can't disclose that number at this time. So hopefully we'll have more information, I hope, after Clinical Congress and in time. If not at the next webinar, which is October, I'll have hopefully something for you all in January, which is going to be our next scheduled webinar. Again, I know some people are starting to gear up and ask us questions, well, how is this going to impact your site visit in the near future? And I just want to let everyone know, I went through, or I should say I was here when we transitioned from the green book to the orange book. Yes, I'm dating myself. And I just want to let everyone know, we do provide centers a grace period, if you will. So we're not going to transition and expect everyone to have a site visit a month after it's been released. So there is going to be a grace period. Ideally, the grace period's 12 months from the date of the release of the manual. That's what it's been. If they provide more time, that's great. So it's going to probably be a year after the date of the release of the book. We don't have a confirmed date of when that book is going to be released. As I said, we are still working through it. Olivia and myself are working on these chapter revisions nonstop with the chairs of the verification committee and Dr. Nathan. So work will still continue. And again, I hope to have more to report in October, and if not in October, again in our webinar in January. I apologize now that I cannot answer specific questions specifically to the registry at this time, because changes are still pending. So thank you again for attending our webinar.
Thank you, Trauma Verification staff, and thank you everyone for attending today's webinar, Trauma Verification September Q&A Web Conference. If you have any other questions, please contact cotvRC@facs.org. On behalf of Trauma Verification and our presenters, thank you for joining us today, and have a great rest of your day.